Okay, I think it's a good time to start, Hussam.
Okay, sure.
Okay, sure. At the beginning, I would like to thank the Continuous Education Department to give us the opportunity for Neurosurgery Department so can present the grand round today. And it's my pleasure to introduce my colleague, Dr. Hussam Jabri, who is a consultant neurosurgeon and spine surgeon. He did his training in a complex spine surgery and minimal invasive, including the endoscopy. Today, he's going to present the endoscopic spine surgery. He will go through the introduction to the endoscope and spine and the treatment. He's going to show some cases as well. So please, Dr. Hussam.
Thanks for continuous education in our hospital and for the department giving me this opportunity. Thank you, Dr. Abdulkarim, for this introduction. I will talk about endoscopic spine surgery this afternoon. Definition. Sorry if you can minimize this. Full endoscopic spine surgery represents the evolution of minimally invasive spine surgery access to the spinal pathology. Surgery will be same as open surgery, but the approach or access to the pathology is much smaller. It's more time consuming for the surgeon and has more radiation exposure, but this is in the benefits of patients, as we see in the coming studies. And this can be neglected by navigation, which can reduce the radiation exposure dramatically. It is done using uniportal or biportal. The difference in biportal is the surgery is done through one port and the illumination and the other port, as we see here, the illumination. In uniportal, the whole surgery is done using only one port. Technically, they are the same, but it depends on the training. A lot of surgeons can use both techniques. In order to go inside the spine, either uni or biportal, we can go posterior laterally, as we see in this picture, through the foramen, or we can go directly in the interlaminar space posteriorly. What are the advantages of endoscopic spine surgery? It has less tissue dissection and muscle trauma, hence reduced blood loss, less damage to the epidural blood supply, and consequent epidural fibrosis and scarring, which eventually lead to reduced hospital stay. Early functional recovery and improvement in the quality of life and better cosmesis. As we see, the surgery in open techniques is much bigger scar compared to less than 1 centimeter scarring and wound caused by endoscope. Characteristics of a spine endoscope, it is like endoscope in any other specialty, but the optical angles and the dimensions and the length are adapted to the spinal pathology. They magnify the anatomy while providing a source of illumination and precise visualization. Unlike microscopes, endoscopes provide illumination at depth and can be positioned directly over the working area to provide unobstructed vision. Angled scope, as we see, this is a scope with 30-degree angle of the optics, are used in lumbar and thoracic. Less angles are used in other parts of the spine, and also it depends on pathology. Like in stenosis, we prefer to use bigger angle compared to the disc. They provide a viewing trajectory that is oblique to the anatomy. They can be used to look around the corners or edges that cannot be viewed with 0-degree scope. And as we see, this is 177 millimeter, which means 17 centimeter. And this is less than 0.7 millimeter. And the working channel is around 4 millimeter here with the light source, camera, and the suction. Spine instrumentation endoscopy is like spine instrumentation in any other minimally invasive or open procedures. But as we see, all the instruments are long and thin to adapt the endoscope. We have the pituitary rongeurs, we have the needle and the cannula where we start the surgery. Then we use the dilators to dissect the muscle, not to traumatize it or burn it. Then we use the obturator to introduce our endoscope with a working channel. Longer tools often dampen or reduce the feel of tissue planes, and the surgeon has to rely heavily on the visual characteristics of the tissue for identifications. This is endoscopic picture through transforaminal approach, and we can see the anatomy. It is a little bit different angle compared to open or minimally invasive approaches, but again, the anatomy is the same. We have the flavum ligament, epidural fat, traversing nerve root, and the PLL, posterior longitudinal ligament, and we have the disc space. This is only the working area, it is so limited. Historically, posterior lateral access was initially used for vertebral biopsy, chemonucleolysis, and other discogenic back pain procedure. But the dimension of the safe zone to land into this area was not clearly defined yet. In 1990, Camden, who is Indian American orthopedic surgeon, described and illustrated the safe triangular working zone. And this depiction from his original article in 1990, and as we see, this safety zone is illustrated. This is the triangular safety zone where our endoscope will land here. It's bounded anteriorly by the exiting nerve root, inferiorly by the end plate of the lower vertebra, medially by traversing nerve root, and posteriorly by the superior articular facet. In 1997, another surgeon called Anthony Young adopted this safe triangular zone, and he is a Chinese-American surgeon. He developed the first ever spine-specified endoscope and called it YES. YES stands for Young Endoscopic Spine System, and it was manufactured by a German company called Richard Wolf. It gained FDA approval on the same year, and after which modern endoscopic era of spine surgery has started. Young's technique was initially, because of a small working area, he was thinking of creating cavity inside the disc, then pulling the extruded fragment or the herniated fragment through this cavity, then take it away. And he did his study retrospectively in 2002 and included 300 patients. And the study group reported it is compared, the result is comparable with the conventional open surgery. In 2005, another German surgeon described the outside-in technique because he started enlarging the foramina or doing something called foraminoplasty using reamers. He was able to remove it from outside and go even inside to remove more disc to prevent recurrence or reherniation. And he reported 95% success. Nowadays, not eventually all foramina need to be enlarged because of the improved optics and lower diameter, smaller diameters of spine endoscopes. What type of anesthesia we are using and why? It is possible to perform this procedure under local anesthesia because the actual tissue dissection is very limited, so pain is limited. The procedure based on the principle of sequential dilatation of soft tissue, and the only significant pain generator during the procedure are the skin and the annulus, fibrosis of the disc. The pain and discomfort can be well neglected with the infiltration of local anesthesia during the procedure and when we reach the annulus with epidural block and conscious sedations. Why we need sometimes to do these surgeries under local anesthesia, and we prefer even if the patient is fit for general anesthesia? Because of limited endoscopic field and poor tactile feedback obtained from long endoscopic tools, Surgery also performed at depth with less familiar anatomy for most of spine surgeons who most likely did not have training on that or special fellowship on this. So with the poor three-dimensional spatial orientation and more radiation exposure. For these reasons, iatrogenic neural injury increased, and the safety of this procedure is amplified when you can communicate freely with the patient under local anesthesia to monitor pain if you are pressing on the exiting or traversing nerve root or the thecal sac. The patient can immediately refer to you that he has pain or numbness during the procedure. So this is a very important reason. Another reason for local anesthesia, elderly patients who are usually associated with medical conditions like diabetes, hypertension, and cardiac diseases. They can better tolerate percutaneous procedures both intraoperatively and postoperatively because this type of procedure can be performed under local anesthesia. Indications have been expanding. First, it was restricted to lumbar region, but now it can be used in cervical and thoracic region. Previously, endoscopy used only for disc herniation, but now it is used for all type of disc with migration up and down. It is used also for spine stenosis and endoscopic assisted fusions using it with open oblique lumbar interbody fusion, and it is also gradually now applied for tumors. Indications for lumbar discectomy procedures is like any indications for lumbar discectomy in general, using any technique. It is positive straight leg raising test, radiating pain with or without neurological deficit. Leg pain is more than back pain, sufficient conservative management, and radiological examination, MRI and CT scan confirming the causative pathology. If we take examples of indication for lumbar spine, it is all discs, foraminal or extraforaminal. First few cases, smaller herniation at disc level with no migration, the located paramedia may be good to overcome the learning curve of these techniques. But which techniques should we use? We agreed that all discs can be approached, but should I select transforaminal or interlaminar? If you go back to anatomy, the intervertebral foraminae are getting smaller as we move down in the spine, but the interlaminar windows are getting bigger in the lowest part. So intuitively, we can do transforaminal here, but it is more difficult here, so it is more easier here to have the interlaminar window. So upper transforaminal, lower interlaminar approach. Now, what are the contraindications, or we can say even relative contraindication? In L5S1, as we see in this picture, particularly in patients, they will have long iliac wings. And this can make the angulation to approach the transforamina very difficult, but we can still use it. To access the area interlaminary. But if the disc is located in the foramen or extraforaminal, and we want to approach it transforaminal in L5S1 with the high iliac crest, it's difficult. But also we can go trans-iliac crest, which has been published like 7 years ago, and you can still approach this disc using the trans-iliac crest. So it is the relative contraindication. Extensive migration can also be an issue, but again, if the disc is here and migrated up, we can go translaminar. So it is relative contraindication in the beginning of the surgery where the surgeon is having the learning curve. Extensive calcification remains honestly contraindication. Maybe all discs are not eligible for endoscopic spine surgery because you have to drill the disc, and drilling and using endoscope is time consuming. Complications, it is more or less like general complication of any spine procedure. Add to that perforation of the peritoneal sac and the abdominal contents if the surgeon is not adherent to the technique and is going too lateral. Missed fragment, injury to neural vascular tissue. Again, it is all the same as other disc procedure. Early complication, psoas hematoma, postoperative hematoma, cerebral spine fluid leak, infection, and the delayed complication remains as other techniques approaching this pathology, recurrent disc herniation, and possible instability. If we want to plan our surgery to do transforaminal disc, for example, we request MRI and CT scan, including full abdominal girth, so our measurement will be accurate on MRI and CT scan. So we take the distance to the foramen and the angulation in the foramen, then we transfer this under fluoroscopy on the patient back on the intended level to treat. And as we see, anatomically, we have general guides, but every patient is variable. Also, the level is variable. But in transforaminal, it's around 8 to 12 centimeter. And extraforaminal, you come more steep. So if you want to target a disc here at any level, definitely you have to go shallow. But for foraminal, extraforaminal, you have to go more steep. In order to transfer the safety zone of cambing on imaging on the patient, we have to follow the guidelines where in AB, our needle should not go more than medial pedicular line, and in the lateral fluoroscopy view, we have not to go more anterior to the posterior vertebral body. So, as we see in this animation, the needle and the stylet is introduced in the safety zone according to measurement on radiological pictures and according to our application on the patient and the location of the disc. Now the dilators is inserted. Now we put the obturator and then we put the adapter to the working cannula, then the endoscope is introduced, and then variable instrumentation is introduced according to our preference. And in this video, as we see, we are drilling the superior articular facet, after which immediately we identify the ligamentum flavum, then we split it and start to remove it from its attachment. Epidural fat is identified, and the lateral edge of the dura with the the traversing nerve root is identified. Now we use the cannula to retract the neural tissue by rotating it, identifying our disc pathology, then removing the disc. Ball tip probe is used to check the adequacy of disc removal and to check for any residual. Then the surgery is completed by coagulation using radiofrequency monopolar system. And this surgery is done without any trauma to the posterior ligamentous complex. In medicine, now we are talking about evidence-based medicine. You can advocate any procedure, but what is your evidence? This study published in 2019 by a study group from Weill Cornell University in New York, led by Dr. Roger Hartel, about the benefit zone of full endoscopic spine surgery. And they have 5 RCTs published about discectomy by either ways with a follow-up of 1 year to 2 years. And these results will be depicted in this diagram. This study compared endoscopic approach in green to SPORT trial, which is a spine patient outcome research trial, a study done on discectomy with follow-up of 4 and 8 years in the States. Both of these RCTs showed that green is the endoscopy has less infection, less dural tears, less overall complications. Yet it has higher herniation rate, but these small herniation rate are more or less remodeling rather than a surgery needed because the operation rate is less. So we have residual disc, but this did not require reherniation in most of the cases. And if we want to compare the full endoscopic spine surgery to traditional open surgery in green and comparing complexity to complication, as we see, the complication in endoscopy is less than traditional open surgery. The complication expected to increase with more complex surgery, but the safety zone of endoscopic spine surgery, or the benefit, it is in moderately to a little bit complex surgeries. Another article published in the Pain Physician Journal in 2016 with the title Full Endoscopic Procedure versus Traditional Discectomy Surgery for Discectomy, a systematic review and meta-analysis of current global clinical trials, showed the conclusion. Based on this meta-analysis of 2 years clinical result, we concluded that full endoscopic procedure is as effective as traditional disc surgery, but has the additional benefit of lower complication rate and superior perioperative parameter. In addition, patients may experience less pain with full endoscopic techniques due to smaller incision and less operative injury. Another article published in 2017 with the title of multi-level spine endoscopy, a review of available evidence published in the European Journal. This is now level 1 evidence to show that outcomes following transforaminal endoscopic surgery are at least equivalent to those after open microdiscectomy, with the expected shorter operation time, less requirement of analgesia, reduced duration of postoperative disability, more rapid rehabilitation, and lower cost of care. Another study published in Journal of Orthopedic Surgery in 2018 with the title Cervical Endoscopic Spine Surgery, a review of current literature. This reviewed the literature comparing to 52 papers on open technique and revealed good excellent result in cervical endoscopic spine surgery in 91% of cases. Patient had 72 less back pain according to the visual analog score scaling of pain, and 80% less arm pain compared to open group at 6 months. And the article of the Surgeon Journal of Royal College of Surgeons of Edinburgh and Ireland, published in 2012 with the title Transforaminal Endoscopic Spine Surgery, the future gold standard for discectomy, a review. Their conclusion: RCT evidence, including our own, suggest that outcome at least equate and probably better than those for microdiscectomy. The majority of patients are treated in daycare facilities, leading to cost saving, minimization of scarring, making secondary surgery easier, and is thought to lead to less long-term low back pain. Another article published in 2018 with the title Comparison of Percutaneous Endoscopic Lumbar Discectomy and Open Lumbar Microdiscectomy for Lumbar Disc Herniation in Korea, a meta-analysis. This meta-analysis found that PLAD, percutaneous endoscopic lumbar discectomy, has significantly better result compared to open lumbar discectomy in the VAS score for pain measurement, ODI for disability measurement, operative time, hospital stay, and surgical treatment for lumbar disc herniation Korean population. All of these collectively will decrease the cost on hospital treating these pathologies. Another article published in 2017, and it is comparison of 7 surgical interventions for lumbar disc herniation, a network meta-analysis published by a group from China. This meta-analysis provides evidence that PLAD might be the best choice to increase success rate and decrease complication rate. And they found, compared to open technique, it is best to they said that open technique might be the best to decrease the operation rate, but also this study group has adopted the endoscopic spine surgery recently in their practice, but with advanced techniques, even their operation rate will drop. So in conclusion, although There is a learning curve associated with these procedures. Endoscopic techniques offer a more powerful and less morbid approach to spinal pathology that ultimately elevate the standards of care when treating our patients. This decreases the operation cost of the hospitals and countries, and endoscopic spine surgery technique represent another tool in the surgical armamentum of a spine surgeon to treat spinal pathology using these principles. Thank you.